For our next session, we have a specialist in clinical trial development, low-grade ovarian cancer, endometrial cancer, and novel targeted therapies and immunotherapy. Dr. Brian Slomovitz is Director of Gynecologic Oncology and co-chair of the Cancer Research Committee at Mount Sinai Medical Center in Miami Beach, Florida. And I am so sorry if my voice is annoying. This is what I've got today. He is also a professor of obstetrics and gynecology at Florida International University. Dr. Slomovitz is a member of the board of directors at the GOG Foundation and uterine cancer lead for GOG Partners. He is also the national global principal investigator on a number of GOG Partners, NCI, and Alliance Foundation clinical trials. He authored more than 150 peer-reviewed articles and lectured extensively nationally and internationally. Dr. Slomovitz graduated from Rutgers University, New Jersey Medical School, my home state, and completed his residency at New York Presbyterian Cornell Medical Center in 2002. At MD Anderson Cancer Center, he completed a fellowship in gynecologic oncology in 2006, and he is board certified in both obstetrics and gynecology and gynecologic oncology. Please welcome Dr. Slomovitz.
Thanks for that introduction, and it's really an honor and a privilege for me to be here. I think when we go out and we do a lot of talks and things like that, the most influential group and the important group, and I would say maybe even the meaningful group, is to talk to patient advocates, because what we do in order to improve the lives for our patients and to make, and that's the most important, and to see, have the opportunity to interact, to talk, to answer questions, to sort of make things simplify and tell you what we're doing. I think for me, it helps keep the pulse on what we're doing. So it's there's a lot of things, but also it energizes us to continue to move forward to come up with better treatment options. So thank you for having me. As mentioned, I was born and raised in New Jersey. I was born in Bayonne and Hudson County. I grew up in Union County in Westfield. But then I did my undergraduate work in Rhode Island. I did my med school training in New Jersey, my residency in Manhattan. But I think the most influential years of my career were right down the street over at MD Anderson. That's where I did my 4-year fellowship in gynecologic oncology under the leadership of Dr. Gershenson. He and I get along great, and I know probably some of you know him from either conferences or patient interactions. And if he were here, I'd say everything about him if he was here as if he's not here. So, but I like to make fun of him. So he went home early because he needed his nap. So well, let's hope that he's getting in getting his rest in. So, and it'll be. No, he's great, and he's been a mentor towards me. And I know tomorrow you'll have Rachel speaking to you as well. And she and we've created, under their leadership, a nice team of investigators. I wouldn't say who's doing the research, because a lot of investigators are doing the research, but helping to lead the trials and helping to put a good team together to ultimately come up with the right trials to make the lives for our patients a lot better. After Anderson, I went back to, I have regrets that I didn't stay in Houston, but I went back to Manhattan for a little while in practice, New Jersey in practice, and then I had the fortune to move to Miami in 2014, where I was at University of Miami, but now I'm at Mount Sinai Medical Center right there on Miami Beach, leading the division there, and we're proud of what we're building there. And we're really focusing on helping make the lives of our patients better. So, and with the GOG, I should add, I serve on the leadership there. GOG is a gynecologic oncology group. We lead both the NCI-sponsored and the industry-sponsored trials throughout the country for in women's cancers. And I know Dr. Gershenson talked about it. I'm not going to go into it a lot, but there was the GOG 3026, the low-grade trial that we presented. He presented some of the results of ribociclib, which was a positive trial. And we're actually working on that earlier today, working on the publication. So it's these large cooperative groups that allow us to change the standard of care moving forward. I like to be informal. If you have any questions at all, just raise your hand. We could ask a question and answer later on, but I'm happy to answer any questions you have. There's no question that's too silly or too stupid. So it's only what we learned. If the only question that's not a good question is the one that you don't ask. So ask any questions, please. And I wanted to, I didn't want to give you a regular, well, here's the trials and here's our data and what our next steps are. I mean, I think those talks are important. I'll try to stand in front of the microphone. Those talks are important, but from a patient perspective, it's really important to better describe and tell you why we do what we do, where we started, where we are, and where we're going as far as the treatment of low grades. So, the learning objectives here, and I focus on the words a little bit, but I just want to give it in context. When we first started studying low grades as an extension of ovarian cancers, as something that came from these borderline tumors, we said, okay, they're ovarian cancer, let's treat them like ovarian cancer. So historically, low-grade cancers of the ovary have been, and in some studies still are, lumped together into ovarian cancer trials. And we're really doing a good job at separating that. But so we started treating, and we'll go through the problems with that, low grades as part of the whole spectrum of ovarian cancers. Then we shifted away from that up until now, and in the near foreseeable future, using drugs that we called, what I like to call repurposed drugs. Drugs that have been approved for other disease sites that make sense to use in low-grade cancers. A lot of them are breast cancer drugs. Sometimes there's melanoma drugs, and we'll talk about that. But that's really about what we've been relying on since Gersh and his team came up with this two-tier grading system: low grade, high grade, separating out the low grades more and more. We're using repurposed drugs to better treat patients, and we'll talk about that. And then then lead into the FDA, the introduction of what it takes to get an FDA approval. How FDA approvals are sort of the holy grail of a drug working against a disease, and how we've done really worked to get an FDA approval, and we're really on deck for one within the next couple of months, hopefully, specifically for low-grade ovarian cancers. So it's using the drugs for ovarian cancer as a whole, to using drugs for other cancers that work in low grade, to hopefully getting an FDA approval. So, and a lot of this information you may know, or it was reviewed, or maybe even be too scientific, but low grades are different than high grades. That's why that first concept of use all drugs for ovarian cancer together doesn't work. Low grades are rare. They make up only 5% of epithelial ovarian cancer. Again, I know you know this information, but I want to put it in context of why it shouldn't be high grade. They grow slowly. They often relapse. The inner workings, the mutations that we see in low grade are different than the mutations we see in high grade. And they just, they just don't play like regular ovarian cancers. They don't act like regular ovarian cancers. They don't need to be with ovarian cancers. So when we talk about that biologically symptomatology treatment, we know that we need to come up with better treatment options outside of low grade. There's no FDA-approved drugs, and we're going to talk about that. Chemotherapy, I don't want to say doesn't work, because I have a lot of patients who have had low grade who chemotherapy works, but it's less likely to work in patients with low-grade serous ovarian cancers. That being said, it's still a standard of care for most patients in the first-line setting, where we're doing trials to hopefully go away from. But the response rates could be as low as 4 to 15% for patients treated with ovarian cancer drugs, typical ovarian cancer drugs, in the low-grade setting. So clearly we need to do better. There's a lack of effective treatments, chemotherapy ineffectiveness. And one of the big problems, and that's why I really love when these groups get together and there's more and more advocacy groups. I'm getting involved with the one that I think they're a sponsor here, the one, Not These Ovaries, or out of Miami, the Campbell team. So, but it's important to get together. It's a small patient population. You all need to stick together. You need to fight. You need to have your voices heard. Because in the absence of a ton of cases to study, we need to better evaluate those patients who have this disease so we can come up with scientifically relevant conclusions, even in a disease that doesn't affect a huge number of patients. But obviously, coming up with a important treatment breakthrough in this small patient population is important. So historically, as I mentioned, they're grouping them all together. But again, these are low-growing chemo-resistant tumors. Platinum-based therapy, chemotherapy, and surgery is sort of the standard of care. In patients with high grade, we're going more towards chemotherapy first. We're not sure if that's going to play out. I know there's been some studies looking at what we call neoadjuvant chemotherapy, neoadjuvant targeted therapies for low grade. But there's still a lot that we need to learn, and it's important that we separate it out. Having the same assumptions, we can't. We can't just assume just because it works in a high grade that it'll work in a low grade. And we're getting better and better at realizing that, and I think as we move forward, we'll see that more and more. So there's the challenge. The challenge is, and what we've gone away from treating them all together, is because they are different tumors. Some more specific differences here: slow growth rate of the low grades versus the rapid rate of the high grades. We talked about the chemo response. We talked about the different molecular drivers, something called MAPK alternatives. I know you had to talk earlier on some of the translational work that they're doing at Anderson. MAPK alternatives are higher in low grades, as opposed to the more typical, what we call P53 high-grade tumors. Clinical behavior: patients can remain stable longer, but they're less chemosensitive. This is the difference. This chart really separates why low grades needs to be different. In my mind, I consider like a low grade, I tell patients with low grade cancer, we treat them like breast cancer patients. They start on a different organ, but their responses to therapy, the long, prolonged activity, the slow-growing nature oftentimes makes them more similar. And we can see, this is a sort of a higher level, looking at some of the intricacies of the pathway, but these are estrogen-driven tumors. Sometimes we see the HER2 amplification. I was talking about this with someone earlier, may be exploited in these tumors, not something we normally exploit in ovarian cancers, but something we could look at just like in breast cancers. Some of these pathways that are highlighted here in the low grade aren't the same pathways that are in the high grade. And then the drugs here that are shown, the Pelicib, everolimus, temsirolimus, some of the CDK4/6 inhibitors, these are the ones that we're investigating and have investigated, will continue to investigate, particularly in the low-grade tumors, looking for better treatment options. The MAPK pathway is highlighted here. We'll talk about that later when we talk about FDA approval. So we need to do different. We need to separate a MAP from a low grade. So why do we repurpose drugs? Why do we say, well, let's pick up a drug and use it, even though you don't have approval in ovarian cancer? Why are we going to use it? It's a lot cheaper to investigate, to make an assumption that it works and to see it works. We're using breast cancer drugs, okay? It's a lot more effective, and I'll go through some of the actual statistics, but it's not creating the wheel all over again. It's saying we have a hormonally sensitive tumor, like breast cancer. It's a tolerable, safe therapy in given to breast cancer patients. Let's do a smaller study, not a 400 or 500 randomized controlled phase 3 trial. Let's do a smaller phase 2 study to see if it works. We do the phase 2 trial, which we've done before. It works. We get something called NCCN listing, which is what we call a compendium listing. Another way of saying it is insurance companies will pay for something if it's in the compendium listing, if it's not FDA approved, right? So a lot of times we worry about the expenses of things. If we were going to rely on insurance companies just to pay for things if they're FDA approved, there would be no treatments for low grade because nothing's FDA approved for low grade. But if it can get a compendium listing based on a smaller study, smaller, costs less, which is important because monies are limited, needs less patients, then we can get this compendium listing, which is important. Repurposing drugs uses proof safe and effective drugs. We're not using drugs just for the first time when we repurpose drugs. Again, we're using drugs that are approved for their indications to see if they better work in this disease setting. So when we talk about the chronology of trials, phase 1 trials are usually not disease-specific, they're safety. Can you give a drug to a person, and is it safe? When we repurpose drugs, it's already gone past that phase 1 clearance. They're already, I don't want to say without side effects, but they're a tolerable, relatively safe adverse event profile. And they're effective, obviously, when we repurpose them in other areas, and we want to see if they're effective in this disease site. For example, looking at the top, for de novo drug development, if we weren't repurposing them, 3 to 7 years to do the basic science work, first in human, first in animal studies. Then there's preclinical research. Will it work in ovarian cancer? Will it work in a certain cancer? 3 to 4 years. Clinical research, 5 to 7 years to do. And then the registration process itself can take 1 to 2 years. So you can see, starting from scratch to get a drug FDA approved could take 13 to 15 years. Forget about, let's just be emotional about it. Like, no way. I'm from New Jersey, so I know I'm in Houston. I got to be careful of some of the words I may say. No effing way. I mean, you're not going to wait 15 years for a drug to get approved, right? I mean, you're like, the time is now. We need to get the drug going. I know in Houston, I got to be very polite. I've said some jokes before in Houston that I probably shouldn't have said. So maybe there's a reason why I didn't move my practice to Houston, but I'll be careful. No, but we want a drug, right? We want a drug that works, and we don't want to wait for the normal process, right? And we know that sometimes shortening the normal process works, unrelated, but we saw that in COVID, right? Regardless of whatever you want to say, I'm not saying who made any decisions what, but the reason why we treated COVID so quickly is because they went outside of this routine. It didn't take us 15 years to get a vaccine. It took us a lot less time because then the adjustment there wasn't repurposing drugs, but it was doing phase 1, 2, and 3 at the same time. And that's how we got a treatment. So it's important to think outside the box, because imagine if we waited like 15 years to get a vaccine for COVID. I mean, it would have been more disastrous exponentially than what it was. So repurposing drug reduces cost and time, reduces some of what's the drug effect on the body. We already know that from other disease sites. Less of an economic risk and requires less of investment. The compound identification, which drug should we use, takes less time. Drug target validation and preclinical research, we're doing that a lot of this in the lab, but are there estrogen receptors on low grades? Yes. All right, let's borrow the information we know from breast cancer about estrogen receptor positive treatments. What about the CDK4/6 pathway? Yes. What about the MEK pathway? Yes. So we're borrowing from what we know. We say like copying, plagiarizing. When you're a kid in school, you sit next to someone, you copy their exam, you plagiarize. When you're a researcher and you borrow something you use an idea from breast cancer, you borrow it. We're going to borrow that idea, which is important because we really want patients to live longer, so we want to get those ideas quicker. We're borrowing the ideas and how they use it in other disease sites. We're doing the studies. We have NCCN listings, on trials as few as 20 patients. Let's get the drugs out there. Let's get it used in our patients. We'll do a phase 2 study, 20 or 30 patients, done, it works. NCCN listing, the insurance companies will pay for it. Let's use it. It's not the FDA approval, the ultimate holy grail, but it's something. It's making a difference for our patients. And then getting indication registration. That's the compendium process that I was talking about. So here's a summary slide. Drug repurposing takes 3 to 12 years. De novo drug design, 10 to 15 years. Success rate is much, 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 much higher when repurposing, because we know these are drugs that work. They're drugs that are already approved. Maybe it's not going to be as successful because they were approved in breast cancer. We have to see if they work in ovarian cancer. Or they're approved in melanoma. We have to see if they work here. But it's a higher success rate. The success rate of a de novo drug design could be less than 10%. Look at the costs here. Cost $300 million for drug repurposing. It's still not cheap. But I'm leading some registration trials now for some of the big diseases that we treat. And I was on the phone with the company. I'm like, how much is this going to cost? They're like, they're being generous. We're going to pay the patients for the drugs and everything for $400 million for one trial, for a registration trial. The cost of this. So, and that's one of the trials. That's not including the phase 1 and 2 and 3. To get to that point. So, there's definitely some advantages in repurposing, and to get the drugs from the clinic to the patients a lot sooner. Talked about this. The importance of shared molecular biomarker-driven pathways. ER-positive biology in breast cancer. The MAPK pathway mutations, KRAS, BRAF, NRAS. We see those in melanoma. We saw drugs that work in melanoma. Dr. Gershenson led the trials of the MEK inhibitors. It got its NCCN listing. Proven therapies across indications. If it doesn't work in breast cancer, we're not sure it's going to work here, but if it works in these other disease sites, it's important to try. Effective breast cancer drugs have been shown to be effective in low grades, and same thing in melanomas, the MEK inhibitors, trametinib. And importantly, and I said it before and I'll say it again, the existing safety and efficacy data. When a patient signs up for a trial, they want to know, is it going to help? But they also want to know it's going to hurt. The first rule of medicine is do no harm. We want to make sure it's safe. Again, repurposing drugs, we're using a set of drugs that already have that safety data behind it. We already know a lot of times people are here on medications, the doctor will say, okay, go home and don't take 2 tablets in the morning, take 1 tablet. So these are things that sound straightforward, but these are dose reductions. There's a lot of studies that go into it that help us say, don't take 2 tablets, take 1, instead of saying take it every other day or take a third of a tablet or stop taking it. So This safety data already exists on repurposed drugs, which is an important part of what we borrow from. So just to go through some of the specific examples, how effective are repurposed therapies? Aromatase inhibitors, a lot of folks here know about them. They're very effective in low grade. They're very effective in breast cancer. We know that they block the peripheral production, meaning everyone has fat tissue. Its fat tissue makes estrogen. Aromatase inhibitors block that estrogen production. Common question I have is, well, doc, my ovaries are out. How can I make estrogen? Why are you putting me on this? Because it's that peripheral fat tissue, the adipose tissue that makes estrogen, that the aromatase inhibitors work to decrease. We know that they could extend progression-free survival in patients with low-grade tumors. Better clinical benefit rate, 60%. Clinical benefit rate, you probably know this, but response means it shrinks. Failure means that it grows. If it's stable disease, a lot of patients say, I talk to patients, I'm like, if you could live the way you are living right now, it's not shrinking, it's not growing, would you take it? And they say, yes, I'll take it. That's the clinical benefit rate, 60%. So there's no limitations to any treatment, hormonal resistance and things like that. But we could see maintenance therapy, letrozole, in patients with low grade, 65-month progression-free survival versus no maintenance therapy, 26 months. Repurposing a breast cancer drug has a benefit there. How about tamoxifen use in patients with low grade? Tamoxifen is a selective estrogen receptor modulator. There's limited response rates, 9%, but in patients treated with tamoxifen, we could see some of the hormonal therapies, the response rate's like 9%, but there's a stable disease rate, a progression-free survival rate. It's not as good as what we see with letrozole. Letrozole, we've seen higher response rates. However, there's still a stable disease rate with tamoxifen of approximately 50%. Other therapies, here's the fulvestrant. It's a selective estrogen receptor degradator. We see stable disease in 40% of the time, so still showing that this is based on a breast cancer study. Another breast cancer drug, another hormonal manipulator in breast cancer, fulvestrant, we are using in patients with low grades, particularly with fulvestrant and combining it with the CDK4/6 inhibitors as a benefit. Again, common theme, repurposing breast cancer drugs, seeing benefits here. And this is a study that I was talking about. This is the CDK4/6. This is a study that I worked on with through the GOG with Dr. Gershenson, GOG 3026, ribociclib. There's other CDK4/6 inhibitors, palbociclib, abemaciclib, made by other companies. They block the cell from progressing, from dividing. We see that there's a super benefit. So what's seen, again, we borrowed from breast cancer. Combine it with a hormonal therapy, it works better. We saw a clinical benefit rate of our trial of 79%, a median duration of response of 19 months with a progression-free survival of 19 months. We actually looked at data just this morning. We got the updated data that we're working on this publication, and I think the progression-free survival is actually going to be higher than this. It's not reported yet, but how cool is that, giving 2 oral drugs to a patient who has disease? We're not saying we get rid of it. It has a good response rate, like 20 to 30%, but you could take this for almost 2 years and it's not going to progress, and it's relatively tolerable. Really cool, really nice. I mean, Gersh is smart. He's not that smart. We just borrowed it from the breast cancer docs. Let's use it, and don't tell him I said. He's napping. He can't hear us anyway. This is a trial that he led, that he brought me on to accrue to, the MEK inhibitor, trametinib. He really changed the world. The team at MD Anderson changed the world with this. Targeted the MAP kinase pathway. Treatments were already established in melanoma, but in low grades, progression-free survival was 13 months versus a standard of care of 7 months. It doubled it. Overall response rate of 26% versus 6%. Very much different. Again, repurposing a drug that was used for melanoma in low-grade serous ovarian cancers. And I went through this pathway again. I don't want to highlight it too much. So what are some of the barriers to successful drug repurposing? There are challenges. Coming up with the right clinical trial design. Again, we don't need to do the big phase 3 randomized FDA approval trial. We need to come up with a smaller study that we could do quickly enough and come up with a meaningful conclusion that we know will help the patients, but it also could help us get approval through to get compendium listing, the NCCN listing, in order for an insurance company to recognize it. So these aren't the straightforward designs. Sometimes we have to be creative in the designs. We need to come up with the right biomarker identification, and does it work with all patients with low grade, or is it a subset of patients based on the molecular profile? based on the molecular testing that we do to see if it works. Regulatory challenges. You can't go to the FDA with a small randomized phase 2. They won't even listen to it. So you have to figure out a way to get it approved for patients, even if it's not getting the holy grail of approval, but getting a NCCN listing. Patent issues. You can't necessarily go to a company and say, hey, let us use your drug for your low grade. We think it's going to work. They have their own interests, their own financial interests in it, and that's why we like to partner with them. With low grades, right now the one where I know they're a sponsor here, and I'm not saying it for that reasons, but the one company, Veristem, is really pushing forward on getting a regulatory approval, which is, we love it when a company is really passionate enough to go for the regulatory approval. When we repurpose drugs, there's a lack of a comprehensive database, and we talked about the intellectual property issues. So what's the approval process? No one has any questions? We could have questions at the end. But, approval process. Preclinical testing, does it work in the lab? Does it make sense? Phase 1, safety and dosing. Again, this is now, we've gone away from treating all ovarian cancers the same, the repurposing. Now the long, tedious process of getting an FDA approval. Phase 1 is getting the safety and the dosing down. Phase 2, is it effective? And what are the side effects? And then the phase 3 are the large-scale effectiveness. Does it work head-to-head to change the standard of care? And then it goes for the FDA approval, 10 to 15 years. What are the challenges in the low-grade setting? FDA approval, rare disease, slow tumor growth, so events don't happen quickly, thank God, but meaning they don't recur quickly. But when it comes to drug development, we need these events to happen in order to get approval, and then limited funding. I sort of went through this already. Timelines for approval. I had this, and I included this slide, but I want to focus on our discussion that we're going to have. And this is really the teamwork. I don't usually use cartoons like that, but I think it's super important. I like this because it shows, brings it all together. In order to get FDA approval, it's just not about a company having a drug that they want to move forward with. It's just not about a group of passionate physicians who want to have a better drug for their patients. It's not about just physicians in the clinic using it, but investigators opening the trial at their site, right? The biggest part, the captain of this ship, the reason why we do what we're doing is because patients are their best advocates. That's why we're here in the room today. We need your support to push the companies forward to work with us, to push the regulatory authorities, the FDA, forward to get approvals, to push the government forward with government funding. It's really, it's a team effort. We can't do what we do without not just the patients being there, but the patients really pushing the system along and teaming with us to get the process going and ultimately get the FDA approvals. Advocacy is key, not only in your care, in clinical trial development, in community outreach and things like that. Patient involvement, patient's family involvement, the team effort. Patient groups really do accelerate the process. And empowerment. Informed patients can influence regulatory decisions and support faster access to more effective therapies. Participating, you know these things. Participating in clinical trials, share your experiences, advocating for rare cancers. So I show this slide, and they're like, "Wait, you have a guy and a girl there?" No, that's the husband, and that's the patient. All right, this wasn't meant to be like, "Oh, you borrowed this from someone else." It's the patient process. Whenever patients come by themselves, I say you need to bring someone. Well, my daughter lives in New Jersey. She'll fly her down. Or get on a Zoom and have, you need to have an extra set of ears at the visit because it's overwhelming. It is completely overwhelming. And I encourage patients to bring, for a lot of reasons, to bring someone there for the support, to hear things twice. But, I'll be honest, I don't want to say things over and over again. Have another set of ears there. I'm joking, but have another set of ears there to listen, to interpret, to process the information. So that's important to do. The future's bright. We're super excited about what we have, where we're going, and what the next steps will be. So I'm really charged up. I'm really excited to see what the next steps are. And as I'm sure you are too. Thanks for your interest, and I'm looking forward to a discussion now. Thank you.
Doctor, I have working. Okay, I have a question. How do you find the drugs can be repurposed? There's so many there.
Yeah, that's a question. So the question, I think, is, how do you find the drugs that should be repurposed? Some of them will work, some of them won't work. It's actually a great question. I think that as we learn more and more about the biologic processes, and we identify that some pathogenic processes are similar between tumors, that's one thing that's sort of showing it to us. The other thing that we're seeing more and more are what we call tumor agnostic trials or site agnostic trials, meaning we're getting some drug approvals not based on an ovarian cancer approval or a melanoma approval or a prostate or a breast approval. We're getting approvals based on HER2 overexpression. There's a new drug, trastuzumab deruxtecan, that we got an FDA approval because they did a study of all tumors, and they found that most of the tumors responded super well to that. So the FDA approved a drug for HER2 overexpression, not based on that. So we need to know what's going on. There's a lot of drugs. We need to be pragmatic and evidence-based on what we choose. And then once we think there's a signal there, we need to explore it with the least number of patients as possible at first. The most precious resources are patients. And if there's an early signal, then going for it. But it's a good question. More questions?
I'm sorry.
So does that mean like a solid tumor, like maybe in the future, like the cancer will be treated not like ways that originate, just like based on the mutation? Is that is the right way to do that?
That's about it. So the question was, so in the future, are we going to treat patients not by where it's from, but the mutation? The answer is 1,000%, yes. We're learning more about the biologic processes. Now, the problem is it's a very complex network. So even though there's one process that's active in a cell, there's a lot of ways to overcome and to resist that. So it's not as simple. It has a mutation in X, so just block that and you cure it. But we're getting more and more to that aspect. Yes. Yes, ma'am.
I understand the correlation between breast and ovarian cancer, but I think it's very interesting, melanoma and low grade. What's that correlation?
Yeah. So I really can't explain very well the why behind it. But we look for the mutation, we look for the processes within the cell that are dysregulated that help drive the cancer. Okay, and that's one of the dysregulated pathways, the MAP kinase pathway, that we see in melanoma, that similarly we see in ovarian cancer. So the why behind it, I'm not sure. Another example, for example, immunotherapies. Immunotherapies like we'll see on the Super Bowl on Sunday, there'll be an ad for Keytruda because they've been on Super Bowl ads for years now. It works for a lot of tumors, but it's like non-small cell lung cancer, melanoma, and then like some cervical cancers and colon cancers. Like, why group those four together? But they all work against, immunotherapy works against them. So it's a good question, but there's no.
So it's MAPK.
Yeah, it's MAPK overexpression, and it seems to work. And yes, great question.
I probably don't need this, but when you say they're going to be FDA approved, will they be FDA approved for frontline treatment as well? Because,
Yeah.
I wonder why, if it's successful later on for recurrence, why is it not used for frontline?
Yeah, no, that's a great question. And that's why the question, if you didn't hear it, is when it gets approved, is it going to be approved for first line or second line, or what it's approved for? That's why, I think the process we have are pretty good, meaning FDA approval, which is very stringent. It's very specific. To be on a registrational trial, it's almost, to sign a consent, like signing a contract. You have to fill in, check all the boxes. Their FDA approvals are based on a certain line of therapy. But that's where the NCCN guidelines let us, using FDA drugs, when we talk about repurposing, sometimes it's the same drug, just repurposing it into a different line of therapy. For example, and I'm not saying this is the case and there's no data on this, but if there's a drug approved for recurrent low-grade ovarian cancer, FDA approval, and there's a smaller study that's done in 50 patients that say it works in the front line, maybe it won't get the FDA approval, that smaller study, but maybe it'll get an NCCN listing. So repurposing a drug that's already approved in the disease for an earlier line of therapy. But I'm not sure. And to say, what will something get approved for? No one knows what the FDA is thinking at any time. It depends on how they look at it.
So it sounds like, over here,
Oh,
sorry. It sounds like ECCN listing is forthcoming for CDK4/6 based on a study that's going to be published. What's that path from the paper being published to the ECC or NCCN listing?
Yeah, that's a great, the question was, how do you get a published paper to the NCCN listing? The NCCN used to meet like once or twice a year to go through the new publications. They're much more lenient now, that if something that comes out that will really help patients, they'll meet more frequently, go through it, and put it onto the NCCN listing. So even though there's like the 25 guidelines, the 24 guidelines, the 23 guidelines, they'll come out with updated versions throughout the year. And there's also examples of drugs getting NCCN listing without the publication, but in general, that's the process. Relatively soon, yeah. And insurance companies, and again, I can't speak for insurance companies, nor would I ever want to, but they'll prove it on NCCN guidelines, but they'll also, if it's not in the guidelines but the paper's out there, as a provider, I've sent in papers and they said, okay, we'll approve it based on that data. So, but this is where the patient becomes their best advocate. If the doctor says, oh no, it won't get approval, it's not this, you say, are you sure? And you investigate, take a deeper dive into it. Yes, ma'am.
I have a question over here.
Question here.
Over here. To your left.
Oh, sorry. I'm sorry. There's a light shining in my eyes. So I apologize.
Have you found any beneficial things for GLP-1s in regard to how fatty tissue excretes estrogen?
Yeah, so the GLP-1s, they're awesome. All right, I'll just say that. And I have opinions on this. I took Mounjaro, I lost like 50 pounds. All right. GLP-1s are going to decrease mortality. Period. In my opinion. I mean, don't say the STAAR Foundation says. You can. Weight loss, obesity, is the #1 cause of death, directly or indirectly, by far. How can I say that? Heart disease, cancer, diabetes, hypertension, they're all related to obesity. So by decreasing obesity, patients are going to live longer. So when we looked at the cancers that are obesity related, the #1 is like endometrial cancer. And my big area of research, in addition to low grades, is endometrial cancer. There's already studies being done out of WashU in St. Louis looking at GLP-1s as a chemopreventative agent for endometrial cancer. So I think, yes, estrogen-driven cancers are obesity-related. I talked about the peripheral fat decreasing the conversions, decreasing the estrogens. I think any way we could decrease the peripheral estrogen production is important, whether it be through an aromatase inhibitor or purely through weight loss is important. And I think that while it's not the #1 cause of low-grade ovarian cancers, it's something that if it doesn't cause it, it attributes to the progression of it, the estrogen levels. So I think they're tremendously important. And the other thing is, insurance companies just say, absolutely not. We're not paying for them. We're not paying for them. Insurance companies, similarly, they say, we're not going to do BRCA testing. It's just too expensive. Insurance companies are slow, and I don't mean to come after insurance companies on this. At the end, you're going to call up Gershenson and says, yeah, he's making fun of you and the insurance companies. But insurance companies don't want to lose money. So it takes them a little time, but they realize that by paying for BRCA testing, they're going to save money in the long run. By paying for the GLP-1s, they're going to save money in the long run. So a lot of my patients, if they were on it for a couple of years, they weren't getting paid for, I tell them to check with their insurance companies now, because a lot of insurance companies start paying for it, because it's going to save them money in the long run. That was a great question. Yes, ma'am.
Yeah, you said repurposing drugs aren't necessarily on our front line treatment right now, but how will that work with like multiple recurrences? Using repurposed drugs, do we still see the possibility of going NED or even getting a cure using repurposed drugs if you've had multiple recurrences?
Yeah, no, that's a great question. I think there's two questions there. It's like, how about multiple lines of therapy with repurposing drugs, and is there still a chance for cure, NED, getting to that point? I mean, yes, we could use a lot of times these repurposed drugs in multiple different lines, so it's not just a second line or a third line or a front line. So yes, we can use them. One of the nice things, I mean, I hate to say there's nice things about cancer, but one of the nice things about low grade is the slow, indolent course. So while CR, NED is our ultimate goal, I have a lot of patients, and we all know of people who have slow, indolent growth of their low grade, that things could be a lot better, the disease could be gone, but things could be a lot worse and it's not going away. So yes, I'd love to get more CRs out of this. Is it possible? Yes. But, but we don't have, we need to get there to make it a reality for more people.
I had a question kind of piggybacking what he had asked. So I was going to ask, you talked about even though the ovaries are removed, the peripheral fat tissues continue to produce estrogen. So how come like these drugs that we're all being put on are causing us to gain weight, to cause fatigue, to cause, bone loss? So most women with estrogen-related cancers gain weight, 15 pounds, I think is the average. So I'm kind of confused on like why we're being given drugs that make us gain weight, which then causes that estrogen production, if that makes sense.
Yeah, I'm going to answer this very, very carefully because I'm going to bring up the word menopause, but it's a great question. Estrogen drives tumors, so estrogenic state for women is from the time they have their first go into reproductive years until menopause, and it's a higher estrogen state. Tissue is it's more elastic. It's more the tissue likes estrogen. The metabolism's better. It's younger and healthier tissue. Things like these are the childbearing years, and I'm just saying this very carefully biologically. At menopause, we see weight gain, we see the hot flashes, we see the bone loss in our patients. While estrogen can cause these cancers by igniting certain pathways, these drugs that we're talking about, the AR blockers, bring on menopause, and if they're already menopause, bring it on worse. Could worsen hot flashes, could worsen the bone loss. So albeit the symptoms are similar of the weight gain, I think you said weight gain 2 or 3 times, which I hear you, they're a symptom of a cause of the cancer, but they're a symptom of menopause, and they're 2 different related, if that makes sense.
And then we're all put on antidepressants, but also gain weight too. So everything's just making us gain weight.
I hear you. Yeah, I hear you. But it's tough. It's difficult. But I hear what you're saying. Questions? Yes.
Hello. So my question here is, we're talking about a bunch of repurposed drugs, and I think that I speak for a lot of us when I say that I know I got freaked out and I started reading a lot about what else I can do once I become NED, because that's always the goal, which thank God that's my condition right now. But I read Jane McClellan's off-label list of drugs that she recommends for people who have had cancer, especially she had ovarian cancer as well. So I was going to ask if you know about any studies that are being done on, possibly taking metformin or like fenbendazole and stuff like that are repurposed for people like us, because I know a lot of docs are kind of against it, and I would like to stay in the state and not have to go through what I already went through.
What's the second? You said metformin. What was the other drug?
Fenbendazole or ivermectin.
Yeah. That's what I thought you said. Yeah. So. Atorvastatin, and what's the other one? Doxycycline, really? Wow. It's interesting. So I have a different view than most doctors. I think, so what you're describing there is, these are really, we're going after anti-aging. Okay, so the drugs that you're talking about, while people with cancer are thinking about using them, when you talk about the folks that are doing a lot of anti-aging research, they're talking about the metformins, they're talking about the mTOR inhibitors. Some of these other, the atorvastatin, the doxycycline, I think there's something there. There clearly is. But to say to someone, and I have friends who are taking some of these drugs because they have nothing better to do, but to say that we have definitive proof, I think we will get proof. I think We don't know which exactly drugs or cocktails of drugs to take yet, but I think there's something there. I would not recommend it. I'm more, my feeling has always been a lot of patients come to me talking about like integrative medicine, more of like an Eastern approach. I'm fine with Eastern medicine. I support it, not as a sole way of treating cancers, but as a supportive way, whether it be through acupuncture or herbs and things like that. But I don't think we're ready. I think metformin is a good drug. I think everyone should be walking around with as low as a hemoglobin A1C as they can. But I don't think we're there yet for prime time as a vitamin type.
So you don't know about any like current research that's being done on it or anything like that? Because I can't find anything that's recent, and I don't want to take medicine for no reason.
Specifically in a low-grade group of patients or in anyone?
Well, there's no specific for low grade for anything. I don't think we're too little. There's too little of us. But I think at least for any kind of other cancer to have some sort of large-scale thing to see if it works for anybody, because having a 10-person study doesn't count, right?
Yeah, I think that we don't have specific studies yet in low grade. I think we're starting to do studies, not in low grade, but in a lot of folks. But I think that it would be premature. It's not ready for prime time to say that any of those is really the be-all, end-all. I mean, my patients say, what do I need to take? I say calcium and vitamin D. Those are the standards, and a multivitamin. And then they go from there. Then if things are okay, the first rule is to do no harm.
Right.
And remember, things could do harm in a lot of ways, but two ways I talk about. They could do harm for their health, and they could do harm for the financial toxicity. You read some of these things, they get these experts panel, they send you a pamphlet, and they say, yeah, for $300 a week, you could take the same medicines. You save your money. They're ridiculous sometimes, but just being honest.
And I'm not one to say nice things about insurance. But again, is it a money thing, or is it really because there's nothing there? That's just, my thoughts.
Insurance companies aren't holding on to a cure for longevity and not giving it because of expense. That I could tell you. They would sell it. That's one of the things to learn. There's always, insurance, they were just saying, they don't want to cure cancer, they don't want to cure this. They're charging a lot of money for some of these drugs, so they don't mind curing some things, in my opinion. Yes, ma'am.
Okay.
You're right on
This will
the
be our last question because we're coming up on time.
Sure.
And then, do you want to hand her the mic? Sure. Okay. Yeah. After this, then we'll move on to our next session.
What kind of comments do you have for those of us who have no mutations, or if we do have one or two, but it's the least common of the mutations for low grade?
Yeah. It's the question, if you can hear it, is, well, what if you don't have a mutation? We're talking about mutations and profiling. It's interesting because we're doing more and more research, maybe not as much in low grade yet, but in other disease sites, that normal mutational profile is actually a biomarker for some of these treatments. So I have a drug that I'm investigating in endometrial cancer, something called selinexor, that we're looking at in endometrial cancers, and it works better in those patients that don't have a P53 mutation. So I wouldn't say that it's doom and gloom. I don't have a mutation, they're not coming up with a treatment for me. So better treatment options may be biomarker dependent, having the biomarker or not having the biomarker. So I think in general, it's early to say everything's biomarker driven, but I would not say at all that not having the biomarker puts someone in a good position or a bad position. For example, BRCA mutations, which I know outside of the scope of this disease, patients would get to, oh no, I have a BRCA mutation. It's not the worst to have the BRCA mutation. It's not the best. It is what it is. But there's different strategies for different ones based on it. So I don't think it's a good or a bad thing. I think it's just a thing that you use to go into a trial or to get a treatment, knowing that if the treatment does work only in those patients with mutation, you could do two things. You could not take the drug. Why? Because you could be on something else that's better, number one. And number two, you don't have to expose yourself to the side effects of a drug that you know is not going to work. Good question.
Great. Thank you all so much for your questions.